Welcome to the Retreat Radio, where we go beyond temporary fixes and surface-level symptom management. Here, we dig into the real root causes behind your symptoms so that you can understand your body, advocate for your health, and ask the right questions. I'm Heather Witt, physician assistant and owner of the Retreat Wellness and Aesthetics. This podcast sits at the intersection of aesthetics, longevity, and functional medicine, and you'll get information without the sugarcoating, the trends, or the nonsense fluff. Let's get into it. Hello, everybody, and welcome back to the Retreat Radio. I am Heather Witt, a physician assistant here in Newport Beach, California. And today we're going to talk about something that I hear almost every single day in my practice when I'm seeing my functional medicine patients. We are constantly hearing patients say that they've gone to their general practitioner or their OBGYN or whoever they're seeing, and they've been told, oh, their labs are normal. They look great, but they're still exhausted. They still can't lose weight. Their hair is thinning. They feel inflamed. They don't feel like themselves. They have brain fog, and they're like, something is just off. This can't be normal aging. There are two main reasons that people are getting told that their labs are normal, yet they still feel terrible. Number one is that a lot of practices are using normal lab ranges. So what this means is that when you get a lab drawn, on the lab where it says your result, there's a reference range in there where it says it should fall between this and this. And those lab ranges take into account the general population. And number two, sometimes they're just not running the right labs in the first place. So you can't even identify what you're trying to measure. Now, this is not to say that traditional medicine or your general practitioner is wrong or they're bad or they're not doing their job. It's just that their role is something completely different than what my role is as a functional medicine provider. So as a general practitioner, their job is to ask, is there something dangerous going on? Is there a diagnosable disease process going on? Is there something that needs immediate medical intervention? Whereas my job, although those things are still important, is to be asking, are you actually functioning optimally? Are you feeling your best for where you're at in life? Because there is a big difference between not being sick and actually feeling well. So today I'm going to break all of that down. We're going to talk about the difference between normal reference ranges and optimal reference ranges. We're going to talk about how those lab reference ranges were created, why they can be misleading, and then finally, the 5 most common labs that we see missed by general practitioners. Because remember, being normal does not always mean being healthy or feeling your best. And if you've ever been told that everything looks fine, but your body's telling you otherwise, this episode is definitely for you. So let's jump right in. So the first thing I want to touch on is normal ranges versus optimal ranges for your lab draws. Most people are going to assume that when they get their report back from the lab, it has your lab number and then next to it, it has the normal range. And if they fall within that, they think, oh, I'm good, I'm healthy. But that is not always true because there is a difference between a reference range, which is going to be what's on that form, and then an optimal range, which is what we often use here in functional medicine. A reference range is what the lab's definition of what is considered normal within the general population. Whereas an optimal range is where we often see people feel and function their best for their age range. So how do labs come up with these lab ranges? They take this from the general population. So this is a very large population of people, and they establish this based on where most of their lab values fall for that given lab. And they usually take about the middle 95%, which is basically everyone. That only leaves about 5% on the end. The issues with this is that that generalized population includes people who are stressed, people who are inflamed, people who are pre-diabetic, diabetic, people who are sedentary, who aren't exercising, people who have nutrient deficiencies, people who are medically sick, they have been in the hospital, they have long-term disease, they're sleeping poorly, all of these things. And so when these things are off, that makes them not as healthy of a person. So their lab values could be very different than somebody who is healthy or who is optimized. And so even though your lab says normal, sometimes all that really means is that you're just statistically average. And I don't know about you, I don't want to be statistically average. So I want to give you some examples of this. For instance, for let's say TSH, thyroid stimulating hormone, which is often the only thyroid lab a lot of people run. A normal lab range on like the labs that we use is 0.4 to 4.5. So first of all, that's pretty wide. And if you have a TSH of 4, you could think, oh, I'm normal. However, in functional medicine, we like to see that range be between 0.5 and 2. So if I see someone at a 3.5 or a 4, I'm thinking, something's going on here. This thyroid is a little bit off here. What can we do to get to the root cause of why this is happening? Another great example that we commonly see, which we'll talk about later, is vitamin D. So lab range is 30 to 100. That's a huge range. 30 is going to be a lot different than 100. We like to see you more between 50 and 80, and I usually strive mostly for about a 60. Oh, another good one is testosterone. Again, if you're even running the right labs to begin with. So for men, total testosterone typically on a lab range is going to be 250 to 900. I can tell you right now, if a man comes in here at 250 testosterone or even 300, they're going to feel like absolute garbage. And they're going to be like, what's wrong with me? But their general practitioner is going to tell them, oh, your testosterone's fine. Don't worry about it. We like to see this number between 800 to 1100 for men to be really feeling their best. Now, I could go on and on and on. I could go through every single lab and tell you the reference ranges and what we strive for here in functional medicine, but we would be here all day. I think you guys get the point. You get the picture. So it's really important that even if your reference range is saying you are normal, I think it's really important to be digging deeper, get a second opinion if you're still not feeling right, because oftentimes something is off and there is something we can do about it to make you feel better. So now that we got all of that intro stuff out of the way, let's jump into the part that I think all of you are here for, which is the 5 most common labs that we see missed on a kind of general lab draw. I want to start first with a thyroid panel. So what I often see when some of my patients come in with previous blood work is that all that was run was a TSH, which is thyroid stimulating hormone. So this is the hormone that's released by the pituitary that then basically tells your thyroid what to do and tells it to actually release the active thyroid hormone. Now, my panel, what I'm going to run here is going to include TSH, but it's also going to include T3, free T4, TPO antibodies, and sometimes a reverse T3 when it's appropriate. And why this is because we see this all the time where your TSH can look normal, but your T4 to T3 conversion is not doing what it's supposed to. So when we run this, your T4 also looks good, but we can see that your T3 is really, really low. So that active thyroid hormone that you're supposed to be getting for your body to use is not happening. So now by running this full panel, I can see that you're having a T4 to T3 conversion issue, and I can better hone in on that and figure out a way of, first of all, why that's happening, but then be able to treat that more fully. Now, the second thing that I love to run on here is TPO antibodies, and I find this all the time in people. So their TSH, their T3, and their T4, so all of their thyroid stuff looks completely normal in good optimal ranges as well. However, when I run those TPO antibodies, they are extremely elevated. This gives us some insight into that this patient likely has some type of an autoimmune process going on, usually like an early Hashimoto's. And although the body is having that antibody attack happening, it's not quite to the point where it's actually affecting the thyroid yet. So their thyroid looks normal. However, by now knowing that they have these higher antibodies, we know that if this is left unchecked and not treated, they are likely going to have a thyroid issue later in life. So this is a way that we can actually prevent disease processes from even happening in the first place. In addition to the thyroid panel that I run, there are a couple of other important things that I always want to make sure I'm running when I'm looking at the thyroid, and that includes ferritin, B12, and vitamin D. And the vitamin D I really only use more so once I actually know that they have a thyroid issue, but we'll get into that. So why do I run these additional things? Because the thyroid does not work in isolation. It's not its own system. All of these other pieces matter and they can affect thyroid function. So let's start with ferritin. This is the most common one. Low ferritin is a big driver of that T4 to T3 conversion. So this is one of the first things I look at when I see that their TSH and their T4 is normal, but their T3 is low, is I can pretty much guarantee your ferritin is probably low. And when I go and look at that, their ferritin is usually within the normal lab range, but it is not in the optimal range that I like to use. And once I fix this number, usually that thyroid issue completely vanishes. So ferritin is a big one. B12 also matters, not necessarily in helping to diagnose a thyroid issue, but that B12 can often mimic thyroid symptoms. So if I look at the thyroid and they're having these symptoms, but their thyroid is completely normal, I can then go and check a B12. Oftentimes that will be low, and that could be kind of one of the explaining factors of why they're still feeling that way. And then why I check a vitamin D if I already know that they have a thyroid issue is because vitamin D plays a big role in immune regulation and inflammation control. And so somebody who does have a thyroid issue, especially if it's Hashimoto's driven, we want to make sure that they have enough vitamin D to make sure we are supporting them in that regard so that we're not making that process even worse. I think that the big thing that I see a lot with the thyroid is that it's often that the thyroid is not the problem itself. The problem is that usually the thyroid is the victim. And so this is why I check these additional things. And I want to make sure that those things are optimized first before I go and start treating the thyroid. Because once I normalize all of that, like I said earlier, most of the time the thyroid will normalize itself out perfectly. The next one is one of my favorites. Who am I kidding? These are all my favorites. But this one is blood sugar and your metabolic status. Typically, a general lab panel is going to run a fasting glucose and a hemoglobin A1C. And a hemoglobin A1C is also something that's very important, not just checking the glucose, because the A1C will tell you the average glucose value over the last 3 months. So this is really great for diabetic patients who clean up their diet the day before they take a lab test to be like, oh, look, my blood sugars look great. But your hemoglobin A1C will always give you away if you have not been behaving. This is great. Your hemoglobin A1C will tell me your blood sugar levels and if you're regulating them well. My panel also includes a fasting insulin. And why this is important is because a lot of people have a completely normal hemoglobin A1C, so their blood sugar is normal. However, if your insulin is elevated, what that tells us is that it is requiring a lot of insulin to keep your blood sugar regulated. And that is an insulin resistance pattern. And just like we talked about with the thyroid, if that is left unchecked, you will likely head into prediabetes and then diabetes at some point later in life because your insulin will eventually get tired and you won't respond to it as much anymore, which virtually is what diabetes is. What this usually looks like, or what insulin resistance usually looks like in a patient, which are the symptoms that they're telling me, even though their practitioner is telling them your blood sugars are fine, is stubborn belly fat is a very big one, difficulty losing weight, fatigue after meals, lots and lots of food cravings, carb cravings, inflammation. This can also mimic a lot of PCOS patterns. You can get energy crashes and just overall feel puffy all the time. So when I find this and I see that we're having some early insulin sensitivity issues, there are things that we can do to help treat that and bring that number down so that your blood glucose can be responding to a more normal amount of insulin and help prevent that progression of disease later in life. Next, let's tackle hormones, specifically the sex hormones. And this one's a big one. So I'm going to keep this very kind of superficial. And I'm going to do another podcast where I go way more into depth on this section specifically, but that's going to take up a lot of time today and not really the point of this podcast. This is the area that I most see patients getting dismissed, especially women. And I've talked about this before on other episodes. The biggest mistake I see is that if the hormones are even run at all, it's usually like one hormone, maybe two. They use the lab ranges and they say, oh, you're normal. Here's a sleeping pill. Here's an antidepressant. Here's something else to like fix all your symptoms. Like you're just aging. So not only is it important to run the correct full panel of these hormones, it's also important how you are running them. When you are going to just like a general lab or your insurance is trying to cover your labs, usually how they are measuring these hormones is through what's called an amino assay. And what we like to use, at least here in our office and in most functional medicine offices, is an LCMS or a liquid chromatography tandem mass spectrometry. That's a freaking mouthful, so we're just going to say LCMS. And what this is a more specified way of measuring these hormones to make sure that we are not getting false lows or false highs. So why is an LCMS standard? It's a really great question. Number one, it's because it's more expensive. Number two, it takes longer. And number three, it's usually not covered by insurance. I went back and I looked at my lab, if I were to measure it immunoassay versus LCMS, and it is 3 times the price when you do an LCMS. Also, when you do an immunoassay, usually it comes back within 24 hours. You can see your results. When you do an LCMS, it usually takes about 5-ish days, sometimes a little bit longer. And then finally, like I said, most insurance companies, because they don't think it's necessary, they will only cover that immunoassay. So if you're getting your labs run by a general practitioner, most likely it is done that way, and it may not be as accurate as it could be. Let's break down each individual part. The biggest one, which is kind of the driver of all of them, is going to be testosterone. But then I'm going to go through some of the other ones as well. Let's start with the testosterone because it applies to both men and women, and it is the most important in my opinion. Most people think that this is just for males. However, testosterone is the most abundant hormone in the female body. It is just at a minute amount that is what's in a male, about 10 times less than what's in a male. So although we still need to make sure this is optimized and you have enough for what the female body is supposed to have, we are not getting you to levels that a male is getting to. And I think this is one of the first roadblocks that people run into when they are trying to get their testosterone treated, is that people automatically think, oh, you need to be careful with testosterone as a female. Like, you're going to grow hair and get acne and your voice is going to get deeper. And it's like, well, yeah, if you prescribe them amounts like you would prescribe to a male, if you're trying to achieve an 800 level like you are with a male, yes, that will happen. But that is not what we're trying to do with a female. We have very different lab ranges we use for them. So it's very important to still treat this in a woman. This can help with low libido. It can help with poor recovery, low motivation, lack of like a spark or a drive for life. This can help with fatigue, mood changes, pretty much anything you're feeling. Testosterone could be a driver of it. Most people are going to run a total testosterone. Maybe. That's if you're lucky and you'll even get them to check your hormones. And a total testosterone is great, but that is literally not going to tell us the picture. So many women especially have a completely normal, even optimized total testosterone, but your body cannot use total testosterone. Free testosterone, which is unbinded testosterone, is the only testosterone your body can actually utilize. So that is the number that we actually care about when we're looking in terms of, is this affecting your symptoms? So my panel is going to include the total testosterone still, but it's also going to include free testosterone, SHBG, which is sex hormone binding globulin, estradiol for both men and women, DHEA, luteinizing hormone, follicle stimulating hormone, and then I usually look at thyroid and your fasting insulin as like kind of a context to the whole picture. Now, obviously, we're not going to be running an FSH in men, but we do normally still measure an LH and a prolactin in men as well. Like I said, total testosterone is going to tell you the total testosterone that's present overall, but it doesn't tell us how much free testosterone is available for the body to use. And that's where SHBG comes in really big. SHBG, you can kind of think of it almost like a storage protein. This is going to bind to testosterone particles, and it then allows that to not be free for the body to use. So it's a binder, hence sex hormone binding globulin. So you can have a completely normal testosterone, but if your SHBG is too high and it is literally binding and eating up too much of your free testosterone, we're not going to have enough free testosterone to give the body the physiological effects that we need from that testosterone. So this is why it's really important to look at that context. And then that's what our next podcast will dive more into is, okay, well, if our SHBG is high, that's great, but like, how do we fix that? And getting down to the root cause of why it is so high is the real thing we need to address, because just giving someone boron to try to lower it is usually not going to be enough. Next is estradiol and progesterone. And although we do still check estradiol in men, we don't check progesterone in men, but we check both of these in women. And this is where a lot of women are also dismissed constantly. because a lot of practitioners focus on one of them and not the other. So they tend to look at estradiol only, and they don't look at progesterone in relation to it. And one important thing, which I have talked about before, is that estrogen and progesterone go together. If we just look at an estrogen level and we see that it looks good, or even if it looks elevated, that's great. But if your progesterone is too low to balance that, even a normal estrogen can throw you out of whack and can give you symptoms. Because the most important thing about these two hormones is the balance between them, not the absolute value of either of them alone. So I usually do measure a progesterone on your first intake, like as if you're a new patient here, but really progesterone is more of a symptom-based hormone. So I go off of your symptoms, and most women I'm finding over the age of 35 need a little bit of progesterone. And if you just give her a little bit of progesterone, you can get rid of the sleeping pill, you can get rid of the antidepressant, you can get rid of the birth control. You don't need all of those things because those are band-aids to the symptoms. The progesterone will actually treat the symptoms, because what's going on in these women is they're having unopposed estrogen. So again, even when the estrogen level is normal, it is putting them into an almost estrogen dominance-like state and then giving them those symptoms. Estrogen, we still monitor that number because we do want to make sure that there's not a process going on where it is a little bit too elevated. And then we also monitor this throughout perimenopause to kind of find when we're really entering into that menopausal state, when our estrogen virtually goes to almost zero. So I still do monitor this in cycling females, but the progesterone is really more the key piece, and getting that first glimpse of where they are balanced together is really, really important. Now, the other important thing is, just like everything else we've talked about, not only is it important to be running the correct labs, but there's additional piece to it. With progesterone, we really want to make sure that we're measuring this on day 19 to 21 of the cycle. If you are not measuring it on that day, it's virtually, in my opinion, almost useless to measure it at all, especially since it's an expensive test. When we go through the cycle of a female, in the beginning portions of it, before we ovulate, we really don't have a lot of progesterone circulating. So if you measure during this time, you are supposed to have a low level. And if you're thinking you should be having a higher level, you're going to think the patient is low, and they might not be. Now, once ovulation occurs, we then get this surge of progesterone, and then we get that drop of it, and that's when then the uterine lining sheds and we have our period. So we want to be measuring during that window after ovulation, when we should be having that peak of progesterone, because if our levels are low during that time, then we know we actually are having a deficiency at the time that we need it the most. So with these two, it more so is the balance between them, not the absolute values themselves, and making sure we're measuring them on the correct day of your cycle to get the most accurate reading. Really quickly, let's run through DHEA and then LH and FSH. So DHEA is an adrenal hormone, and this is a precursor to testosterone. This number can kind of help us to determine, is low testosterone coming from the ovary or the testicle not producing enough? Or is it coming from your adrenal glands and it's just you don't have enough DHEA to stimulate the testosterone to be produced? So this can, again, help us in determining the root cause of low testosterone. Sometimes if this number is low, we can supplement this a little bit to kind of help with the picture. But if we don't have all the other values with it, again, this is kind of a pointless value. Similarly, LH and FSH are also pieces to the puzzle that help us to understand root cause of why something is occurring. These are helping us to understand if your brain is signaling correctly. These are hormones that are produced in the pituitary gland that tell your ovaries and your testes what to do, produce testosterone, let's say. So let's take an example of somebody who we see on labs has low testosterone. We need to figure out, is this basically that the brain, the pituitary, is not actually releasing LH and FSH to signal the ovaries and the testes to produce the testosterone? Or is the problem that this is getting through, but the ovaries and testes are just not responding to it? Because those are two completely different patterns, and we treat them very differently. Whether the numbers are high or low helps us to understand which mechanism it is coming from for more that root cause diagnosis and for better overall treatment plans. So let me just really quickly recap that, because that's kind of a lot of information. Again, we're going to use that example of when your testosterone is low. What we're trying to figure out when we see this is, where is the problem starting? What is the root cause to help better guide treatment? Because sometimes the answer is not always, oh, just give them some testosterone, because that might not be the issue. We look at DHEA to tell us, is the precursor down? Are you just not getting the precursor that you need to create the testosterone in the first place? The second we can look at is LH and FSH. Is the brain signaling appropriately to tell the ovaries and the testes to produce the testosterone? And then third, we can see if all of these numbers are more normal. Is it just that the testes and the ovaries are not responding and just not able to produce the hormone anymore? And again, once we can kind of pinpoint using all of these labs together where the problem is coming from, we can better treat the patient, and we don't always have to jump to hormone therapy if really it's just a problem occurring somewhere else. And this is always what we strive for here. We are trying to treat the root cause. We're not trying to put a Band-Aid on your symptom. Up next, we have B12. Most generalized panels will run a B12 just to see where your energy levels are at. However, I always add on a homocysteine to my B12. And why this is important is because you can have B12, tons of it, circulating in your blood, but your body may not be able to use it properly. And this is what homocysteine can help us see. So this is what we call a functional deficiency, where there's vitamin there. It's on paper, you have it, but your body is not able to actually use this appropriately. And so you're not going to be getting the effects from it, even though your level looks normal. Homocysteine helps us to understand the entire B vitamin pathway, or your methylation pathway, and if it's working the way that it should. I'm sure a lot of you have heard of the MTHFR. I call it the mother effer gene. It's a lot easier to say. And it makes it so that your body is not able to methylate your vitamins properly. And so it's really important that you are taking a methylated vitamin anytime you are, to make sure you can actually process it. But homocysteine is a much cheaper, easier blood draw alternative to kind of giving you a little bit of insight into maybe you are having a little bit of this problem. It cannot diagnose if you have the mother effer mutation, but it can show us if you are having kinks in your methylation pathway, which, by the way, may be reversible. To process homocysteine properly, you need B12, folate, and B6. So if we see a elevated homocysteine, we know that someplace within there, that signal is missing. So if your B12 is normal or even elevated and your homocysteine is elevated, the answer is not just to give more B12, because you already have enough. The problem is that you're probably lacking B6 or folate. And so a lot of times when I see an elevated homocysteine, I give somebody more of like a B complex that has that folate and has that B6 in it, so they can restore that pathway, so that then they can process and use the B12 that they actually have in their system. Because when the methylation pathway is down, if you're not able to process that homocysteine, you're not going to be able to use your B12 either. So adding on that homocysteine is important in knowing exactly what type of compound or supplement you're going to need to kind of fix that pathway. But here's where this whole thing can get very confusing. Let's take another example. Let's say your B12 is actually low. And so you think, oh, let's supplement B12. Let's get some B12 injections. Let's take a B12 supplement. But we really want to figure out, why is it low? Are you having poor absorption of B12? Are you having gut issues? Do you have low stomach acid that's not allowing you to get this B12? Do you have inflammation going on in the body? Do you have a poor diet, so you're just not getting access to B12 to begin with? Maybe there's some medication effects, or maybe your folate or your B6 is low. So again, it's affecting that whole homocysteine pathway. So if your B12 is low and your homocysteine is high, that tells me that the deficiency that's actually affecting how the body functions, it's not just that it's showing up as a number on the lab report. So this makes the deficiency more clinically significant and changes how I'm going to do treatment. Because if we only replace that B12 without taking into account why it's low, we can miss the real issue and nothing is actually going to change and your symptoms will not get better. And finally, let's talk about the lipid panel. I don't want to just know, is your cholesterol high? I want to know your whole cardiovascular risk profile. So a general lab panel for a lipid panel is going to be your total cholesterol, LDL, HDL, and triglycerides. On my panel, I don't just want to know, is your cholesterol high? I want to know what is the likelihood that plaque can form. And so in addition to all of those things on a normal lipid panel, I'm also running an ApoB. I'm also running that fasting insulin, and I'm also looking at a CRP, or your generalized marker of inflammation. This is really going to help us get more into preventative medicine, not just, do you have high cholesterol? Let's manage it. We're really looking at, let's prevent something from happening in the future. But why I add in that ApoB is because, think of it like this. Your LDL, which is the bad cholesterol, we want this one to be low. This is the amount of cholesterol. Let's say this is total passengers on a plane, like if you're taking a trip somewhere, okay? ApoB is the amount of particles carrying that cholesterol, or that LDL cholesterol. So this is the number of flights in a day at the airport. Would you rather have 5 full flights, or would you rather have 50 half full flights? Which one would you prefer? I would probably go for the 5 full flights, because if you take into account the more flights that you have taking off and landing, the more chaotic and the more crazy it is, and the more opportunity there is for complications and delays. So we can equate this to cholesterol in that although your LDL is your total amount of cholesterol, your ApoB is the amount of transporting particles that have opportunities to carry that into the vessel in order to form plaque. So really simplistically, all ApoB is telling us is the higher that number is, the more likelihood we have that plaque can actually start forming. So this is why I say that by running this, we do much more preventative disease. So I would much rather see an elevated LDL, but a low ApoB, rather than a normal like LDL cholesterol, but a super elevated ApoB. That's actually going to be a more dangerous situation, and something that I'm going to treat harder and I'm going to focus on more aggressively than if you have a little bit of an elevated LDL, but your ApoB is totally fine. It's a really hard concept to grasp, but what we care about more is the opportunity for the cholesterol to get in rather than the amount of cholesterol itself. Now, another really cool thing that we can run that I do not run on every patient is something called the lipoprotein A. And this is a genetic marker. This is really great for people who come in who are like, no matter what I do, I'm taking all the meds, I'm doing all the things, I'm eating healthy, I'm exercising, and their cholesterol is through the roof. Likely they have some type of a familial or hereditary component, and we can run a lipoprotein A, and this can usually confirm that for us. A lot of people think, what's the point of running this? Like, you probably can already assume that. But what this can sometimes tell us if we are struggling to reduce those numbers is how aggressively should we really focus on this? Because somebody with a slightly elevated cholesterol level is usually not really like a big deal. Like, maybe we'll throw a couple supplements at it, but we've got time. But if you have an elevated lipo A, we know that you have a familial component. This is something that we're going to more aggressively focus on from the beginning, again, for that more preventative maintenance. Next, why I check a fasting insulin on my lipid panel is because if we remember what we talked about already with our fasting insulin, this can alert us to insulin resistance issues. And insulin resistance issues can show up long before your glucose gets affected or long before diabetes comes into the picture. And insulin resistance is also a major driver of abdominal fat, inflammation, high triglycerides, low HDL, and remember H for high, we want that to be high, and it's also a driver for plaque risk. And so if we see this elevated insulin level, again, we know that this is something we're going to want to work on to bring down so that we can prevent that cholesterol from getting worse over time. So that's all 5. That's the ones that I have for you today. I did just a really brief coverage of all of them. But one thing I really want to hone in on here is something else that I hear a lot is, oh, well, you functional medicine doctors, like, you just want to like order all these tests just to order more tests. And that is far from the case, because if you are not ordering the tests you need to see the whole picture, you are now doing symptom management. And functional medicine, that is the very definition. We are avoiding symptom management. We are trying to get to the root cause of why you are feeling the way you are feeling. When we see a low testosterone, it's not just your testosterone is low, let's treat it. Why is your testosterone low? And we need other lab values to be able to figure out that picture. And by running these additional labs, it has alerted us to so many more things that need to be addressed that then fix a lot of other labs that we would have otherwise thrown a ton of medications at. So the other big takeaway that I want you to take from this is that normal does not mean optimal. If you have ever gone in and you've had your labs taken or you've been evaluated and you've been blown off, you've been told everything is normal, you've been given antidepressants, you've been given sleeping pills, you've been told that this is just life, this is aging, that does not have to be the end all for you. Get a second opinion. See somebody who specializes in doing more of this functional medicine approach and looking at the bigger picture, because I guarantee your labs are either not normal because you're not in the optimal range of where you should be to feel your best, or number two, they didn't order all the right labs to get the full picture and they are missing something. Listen to your body, listen to yourself because you know what's right for your body. And I hope that this podcast was helpful in you and kind of alerting you and opening your eyes to some of these things that can be missed. If you have any additional questions, I always love when people reach out to us. And until next time, I will see you on the next podcast.
The information shared on this podcast is for educational purposes only. It reflects clinical experience and opinion and is not intended to serve as a diagnosis, treatment plan, or medical advice. As always, please consult with a qualified healthcare provider before making any changes to your health, medications, or treatment plan. If you want to be a part of our community, make sure to follow us on Instagram at theretreat.wellness and theretreat.aesthetics. Thank you so much for spending part of your day with me today, and until next time.